I want to thank the Cutaneous Lymphoma Patient Educational Foundation for inviting me today to give this talk on chemotherapy for cutaneous lymphoma, an important topic. I will say that my hope is that chemotherapy goes away for this disease over the next 10 to 20 years. And I think that immunotherapy is a wave of the future for blood cancers in general, and I do think that that represents a distinct possibility based on some of the recent movement in the field. So my name is Mark Fessler. I'm a medical oncologist at St. Louis University. My practice is at St. Louis University Cancer Center. I take care primarily of lymphoma patients, both cutaneous and systemic lymphomas. I am stem cell transplant director at St. Louis University, and I have the pleasure of managing patients, co-managing patients with Yadira Hurley in our cutaneous, multidisciplinary cutaneous lymphoma clinic. So hopefully none of the cutaneous lymphoma patients or caregivers in the room feel this way when they come to seek care for their cutaneous lymphoma. So you see here a anxious patient torn between a dermatologist and a medical oncologist. The dermatologist is carrying a fly swatter. The medical oncologist appears to be carrying a sledgehammer. And you've got a disinterested pathologist there off to the side. So Yadira and I started a multidisciplinary cutaneous lymphoma clinic several years back, and we actually meet with the patient in the same room. We discuss the pros and cons of various treatment options in front of them. We ask each other questions back and forth. Yadira happens to be a dual threat, so she's both a dermatologist and a pathologist. And so hopefully by that multidisciplinary clinic, we are reducing anxiety for the patients and caregivers that have this disease. And here's our website of our multidisciplinary clinic. We will get the slides of skin biopsies in advance or any other biopsies that are performed. We'll perform consultation with a joint visit. We'll review history, physical, laboratory, and we're capable of doing PET scans and blood draws in the St. Louis U Cancer Center. We have access to light therapy, photophoresis, and we can perform the infusion therapies all within that clinic. So let me give you some basics about chemotherapy from my perspective. So it's treatment with chemical substances, either given topically, orally, or intravenously with the purpose of killing cancer cells. Now, prior lectures at this symposium by dermatologists informed on both topical and oral medications, and I think appropriately so. Those medications tend to be more on the domain and expertise of the dermatologist, whereas the somewhat of the oral medications, but certainly intravenous medications are within the domain of the medical oncologist. So both oral and IV chemotherapy act systemically, meaning that they affect lesions at multiple skin sites and even internally. And I saw that the depth that Dr. Carson was going into in his talk on some of these agents, and so this just provides a very basic background in regards to the chemotherapy. So the chemotherapy can be a confusing term in regards to some of the medications used to treat cutaneous lymphoma. I think that this was reflected. Dr. Carson and I were trying to figure out what some of the overlap between our areas were and try to coordinate what medicines were immunotherapy and what medicines were chemotherapy before the talk. So one can apply either a broad or restricted definition of chemotherapy in cutaneous lymphoma as pixarotene a chemotherapeutic, is vorinostat a chemotherapeutic. I think some would say yes, some would say no. And then there's an intersection with immunotherapy. For example, is brentuximab an immunotherapeutic or is it a chemotherapeutic? And I think that there could be certainly some debate on that. In cutaneous lymphoma practice, the intravenous chemotherapeutics are typically the domain, as I mentioned, of the medical oncologist. So the chemotherapy is typically administered through peripheral IV port or another central venous access catheter, which is an important aspect of the therapy. If there's skin disease, infections can become an issue whenever we place central access devices. Chemotherapy is not selective, unfortunately, and that's why I think hopefully immunotherapeutic approaches in treating blood cancers become the wave of the future and eliminate chemotherapy altogether. Chemotherapy damages both cancer cells and normal cells in the body, and each agent has a unique side effect profile. Tolerability of chemotherapy is highly variable, but supportive care in modern oncology is really quite good. Antiemetics are able to eliminate nausea and vomiting for the vast majority of patients, and then prophylactic antibiotics and use of growth factors if needed reduce the risk of infection substantially. So the World Health Organization produces the Bible for blood cancers, and basically this defines all the entities that a blood cancer physician would deal with. So basically both the systemic and cutaneous lymphomas have distinct descriptions and categorizations that are defined in this book, and this is how diagnoses are made. So this is a complicated slide, and I'll walk you through it. Basically, this is the World Health Organization classification of various cutaneous lymphoma entities. So you see that cutaneous lymphoma is divided into both T-cell and B-cell lymphomas. The T-cell lymphoma you can see toward the top of the slide, and the cutaneous B-cell lymphoma you see down toward the middle of the slide. Within cutaneous T-cell and B-cell lymphoma, there's specific entities, some of which have an indolent or non-aggressive behavior, and then there's entities that have more of an intermediate or aggressive behavior. You can see that in the next column, the number of cases per year. So we're dealing with really overall very rare entities. Cutaneous T-cell lymphoma, specifically mycosis fungoides, is the most common entity. You can see the relative frequencies of each of the disease processes on the next column, and then the disease-specific 5-year survival for each of the entities. So you can see quite a range there. Some entities have a 5-year disease-specific survival of 100%, and there's other more rare, fortunately, aggressive entities that have a disease-specific survival in the teens. So the green arrows are pointing out the kind of indolent disorders, and I think it's important that everyone understands that those are the disorders that are typically handled in the multidisciplinary cutaneous lymphoma clinics across the country. Chemotherapy is often less often needed for these specific disorders. Single agent chemotherapy, when it is needed, is typically the modality that's applied, and I'll explain this in a further slide. Typically, patients are not treated with chemotherapy until they have relapsed or refractory disease, sometimes multiply relapsed and refractory disease. And chemotherapy for these disorders are typically given with palliative intent, meaning that the physicians caring for the disease are not trying to eradicate it, but rather to control and improve symptoms with the inevitable likelihood that the disease is going to come back. The red arrows point to the more aggressive disease processes on this slide. These are often managed in a non-multidisciplinary format by the medical oncologist solely, and chemotherapy is often needed, and usually combination chemotherapy. Sometimes the combination chemotherapy is administered as upfront treatment, and sometimes it's actually administered with curative intent for these disease processes. So very distinct difference between cutaneous lymphoma entities depending on the specific subtype that we're dealing with. So this is a typical case of mycosis fungoides with patch plaque disease, and this type of patient would not be managed with chemotherapy typically until very late stages. So this patient would be managed typically with topicals, oral medicines. IV chemotherapy in this context would be a last resort type of modality. Contrast that with tumor stage mycosis fungoides. So this patient's got a sizable tumor on the leg. If that was the only tumor in the body, you're going to hear, I think, a separate talk next on radiotherapy. We'll often use radiotherapy as a modality in an instance like this. If the tumor stage disease is multifocal, I explained to you that the chemotherapy can act systemically, so it acts on multiple lesions within the body, and typically we would use chemotherapy in a situation like that. Dr. Hurley probably went through the staging in quite a bit of detail. This slide just reflects the fact that as you go from T1 to T4, the prognosis gets markedly worse. So when you get into the T3, T4 disease, the probability of the median survival probability is typically less than 5 years. And this becomes a situation where as the disease becomes more aggressive, the prognosis becomes worse. That sort of heightens the concern about the disease, and typically a situation when chemotherapy is then applied. This is an example of somebody with large cell transformed mycosis fungoides. So you can see the multifocal skin lesions that on biopsy produce these, or that these large cells can be seen. You see here the size of a normal lymphocyte that I'm pointing out with the arrow here. And the tumor cells are much larger cells scattered throughout most of the field here. Large cell transformed mycosis fungoides, and really several studies, this one by Greer in hematology oncology, carries a worse prognosis than non-transformed disease. And for that reason, with the multifocal large cell transformation, this is typically an indication for systemic chemotherapy. So just an overview of chemotherapy for mycosis fungoides. We've got single agents and combination chemotherapy. The response rates with combinations and single agents is roughly equivalent. So we typically won't use combination therapy for this particular disease. I'll talk about combination therapy for some other cutaneous lymphoma subtypes. So the single agent therapeutics you see listed here, gemcitabine, liposomal doxorubicin, pentostatin, pralatrexate, are listed in my particular order of preference in terms of the sequence that I would apply them to individual patients. I find that gemcitabine is a pretty well-tolerated chemotherapeutic. It is administered weekly on a 3-week on schedule, 1-week off schedule, so each cycle constitutes a month. And the biggest side effect I see with gemcitabine is fatigue. There's other rare side effects that can occur, including pulmonary toxicity and a rare illness called TTP, or thrombotic thrombocytopenic purpura. Liposomal doxorubicin is typically the kind of second option that we'll go to when we talk about IV chemotherapy. You can see the response rates are pretty equivalent to that of gemcitabine. This is typically given on an every 3 to 4 week schedule, and the liposomal doxorubicin side effects include cardiotoxicity and mucositis as the primary side effects. Pentostatin is another chemotherapeutic agent that's typically given in a 3 consecutive day, every 2 to 3 week schedule. And pentostatin is also a pretty well tolerated chemotherapeutic for the most part. Do see blood counts get low with pentostatin, and there's some immunosuppressive properties of pentostatin that have to be taken into account. And so prophylactic antimicrobials are typically used when this medicine is applied. Pralatrexate is another systemic chemotherapeutic. The predominant side effect here is mucositis. You can see the response rates with this agent are a bit lower than some of the other options. This is a slide. So the National Cancer Care Guidelines are publicly available to everybody, and this is under the domain of non-Hodgkin's lymphoma. So the non-Hodgkin's lymphoma guideline, several pages on cutaneous lymphomas, and this is the suggested treatment regimens for mycosis fungoides and Sézary syndrome. So they categorize the systemic therapies into oral therapies, which most are in category A. There's category B agents and then category C, with kind of increasing complexity and adverse effects by category. So the category A's are the ones that typically we'll start with when we think systemic therapies indicated. I know that Dr. Carson went through extracorporeal photophoresis and interferon. The retinoids are oral medicines, and methotrexate is kind of a classic oral chemotherapeutic that's listed in that category. Category B gets more into systemic options, but there are some oral chemotherapeutic options within there, including cyclophosphamide etoposide, agents that we don't often use. Typically, when we're getting to the point of considering systemic therapy, we'll typically go with the IV chemotherapeutics. So that just gives you a breadth for all the different medications that we have at our disposal. At this point, so this slide basically talks about stage 3 mycosis fungoides, Sézary syndrome. So even when you get into stage 3 disease, chemotherapeutics, so the category B agents, are really not applied until patients are relapsed and refractory, typically to multiple agents. When you talk about stage 4 disease, Sézary syndrome is sort of the top category here. Oftentimes we'll use a combination of therapies, start with photophoresis, we'll use interferon, combine that with some of the oral medication options. And typically, only when patients are relapsed refractory will we consider the category B systemic options. Bottom part of the slide is visceral organ disease and non-Sézary stage 4 disease. These patients tend to have a bit more aggressive illness, and so IV chemotherapeutics, both category B, are typically needed for these types of patients. So an important study was published in Blood 2015 by Hughes. This was a retrospective analysis of 198 patients with mycosis fungoides and Sézary syndrome that were treated with systemic therapy in Australia. And what they found was that the median time to next treatment after chemotherapy was 3.9 months, whereas the median time to treatment with next treatment with interferon was 8.7, and with HDAC inhibitors was 4.5. So their conclusions from the study was that chemotherapy has a limited duration of response and that other options should be tried first. And I think this article is how we've been practicing in cutaneous lymphoma for quite some time. But I think it was nice to have this publication to demonstrate this, and sort of reinforces the concept that we really want to cycle through multiple therapies, oral therapies, immunotherapies, before committing patients to the systemic chemotherapy. So this is a time to next treatment for patients, first line, mid-line, and late line therapies, and you see that the chemotherapy time to next treatment was inferior when you look across the spectrum of when patients initiate treatment for the disease. Immunotherapy is really allogeneic stem cell transplantation, but I thought I'd just include a slide in here since I direct the stem cell program at St. Louis University. So this is basically applying chemotherapy, sometimes with radiation. In this study, they use a skin electron beam therapy prior to the transplant. What the transplant consists of is a different donor stem cells infused into the patient. And this is typically a related sibling, sometimes a 10 out of 10 match in the National Marrow Donor Program registry. Not for this particular disease, but there are starting to be transplants done, haploidentical transplants and cord transplants for other disease indications. So the allogeneic stem cell transplant represents a potential treatment modality for these patients. This is we think, a potentially curative option. You saw the natural history slide that I showed on aggressive mycosis fungoides with T3, T4 disease. So their median survival was typically less than 5 years. This is a series from MD Anderson showing the progression-free survival. So this is patients alive without their disease. And you see the hash marks go out to 4 years, and there's a patient even out to 7 years in their series. So relatively small series of patients. This type of therapy requires very careful patient selection. Takes a very motivated patient, takes a patient with normal organ function, very advanced disease, typically refractory to almost every option that we've used. But it does represent a potentially curable option. You might ask why we don't use this more often if it is curable and these other therapies are more palliative for the disease. And that just really relates to the fact that allogeneic transplant is still a bit of a wild card in regards to graft versus host disease. We really don't know how to select which patients are going to pre-transplant get graft versus host disease, and that can become a fatal syndrome with allogeneic transplant in this disease context. you're talking about a transplant-related mortality within the first 100 days of typically somewhere between 10 and 25%, depending on what series one looks at. So it's usually reserved as, I think appropriately so, as sort of a last resort option, but it can be a consideration that we use for this disease. So I'll talk briefly about other subtypes of cutaneous lymphoma now. These, as you saw on that prior slide, represent much less common entities. So this is an example of a patient with primary cutaneous anaplastic lymphoma. So you see the skin lesions here. Biopsy was done, showed these large, aggressive-looking anaplastic cells. And when a stain is applied to these cells, they all stain typically very brightly for CD30 protein. So this is the NCCN guidelines on primary cutaneous anaplastic lymphoma. And they list multiple options actually for this disease, including retinoids, pralatrexate, brentuximab. That's whether the patient has a regional lymph node or multifocal lesions. I think newer studies are really demonstrating that brentuximab vedotin for these CD30 positive illnesses produces an extremely high response rate, and this would be our typical go-to option for these patients if they don't have pre-existing peripheral neuropathy, which tends to be really the biggest side effect related to that drug. It's only when patients are relapse refractory to brentuximab vedotin that we would consider chemotherapeutic options at that point. Cutaneous B-cell lymphoma, also less common than mycosis fungoides. This patient, biopsy of this forehead rash showed a primary cutaneous follicle center cell lymphoma. A patient like this would typically be managed with a focal lesion that's encompassed by a radiation field. Radiation is a nice option. Sometimes intralesional steroids can be applied for these patients. With this broad distribution of a forehead rash, oftentimes we'll use single-agent Rituxan in that context for 4 weekly dosages, and sometimes put patients on maintenance schedules of that drug. And we've had very good outcomes at controlling the follicle center cell lymphoma with that treatment application. It's typically only when patients develop extracutaneous disease or they're refractory to Rituxan that we'll consider chemotherapeutic options. And at that point, we would consider using PO cyclophosphamide, etoposide, or an IV chemotherapeutic called bendamustine. We found to be quite well tolerated and actually effective for this disease, even though there's actually kind of a dearth of publications on describing outcomes with bendamustine for this disease. This is an example of cutaneous diffuse large cell lymphoma of the leg. So these patients tend to have kind of bulky, multifocal tumors on the leg surface. And the NCCN guidelines for this entity really suggest using combination immunochemotherapy for this disease. So there's a chemo regimen called R-CHOP, Rituxan, and then the 4 chemotherapeutics, Cytoxan, Adriamycin, vincristine, and prednisone. And multi-agent immunochemotherapy for this disease can produce some long-term survivors. I think I showed you on the prior slide that about 50% of patients will be alive and disease-free 5 years after an aggressive type treatment approach application for this disease. So this is typically how this disease is handled. So I'll summarize and have time, I think, time for questions here. So given the broad range of cutaneous lymphoma diagnoses, the goal of chemotherapy should really be clearly articulated to patients. The choice of chemotherapy of palliative intent really relies heavily on patient choice, which depends on expected side effects, costs, and infusion schedules. Patients should have a collaborative healthcare team focused on listening to provide the state-of-the-art tailored care in individual situations. It can be difficult in situations to decide what the next best option is, and it really is considering all the options at every single visit and discussing the pros and cons of each potential option, I think.